Episode 30 Proximal Control Vascular Surgery Exam Prep Antithrombotic Therapy for Vascular Disease ESVS 2023 Guidelines FRCS and European Board Vascular Surgery Exam Focus Teaching. Welcome back to Proximal Control. I'm your host, Momia. This is the podcast where we prepare for the vascular exams the same way we practice as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. Today we are going deep into procedure and patient-specific antithrombotic therapy, various trials and evidence, all from the 2023 ESVS guidelines. So let's start. Let's talk about the benefit versus harm equation. Antithrombotic therapy is a balancing act. Every recommendation involves weighing ischemic event prevention against bleeding risk. Let me give you an example from the guidelines themselves. The classic risk-benefit calculation: single antiplatelet in chronic symptomatic lower extremity arterial disease. For every 1,000 patients prescribed single antiplatelet therapy, 8 cardiovascular deaths are prevented. 7 major bleeding events are caused. So the margin is narrow. This is why risk stratification matters enormously. The balance becomes more favorable as ischemic risk increases. Example, post-intervention, polyvascular disease, CLTI, diabetes, CKD, and so on. Now let's talk about bleeding risk score. OAC-3 PAD, that is OAC-3 PAD, that is WAC-3 PAD, bleeding risk score, you should know this. This score was developed specifically for this guideline from 81,000 patients hospitalized with PAD in Germany. It is the only validated bleeding score developed for PAD population. 8 independent predictors are used to stratify patients into 4 bleeding risk groups. The factors that are considered are: if the patient already admitted on anticoagulation, does the patient have anemia, does the patient have CLTI, especially Fontaine 3 and 4, congestive heart failure, CKD, prior bleeding, dementia, age more than 80 years. And then this gives different scores to each one, and the highest score is given if the patient has anemia. Now, combining all these scores, if you find the score is 0, that's low risk. If the score is 1 to 4, there's a low to moderate risk. If the score is 5 to 9, then moderate to high risk. However, if the score is 10 to 33, that is high risk. So, you remember, anemia scores the highest, that is 8 points in WAC-3 PAD score. This is clinically counterintuitive to some, but anemia is the strongest predictor of bleeding in this population. Now, what about proton pump inhibitors? The one modifiable risk reduced with RCT evidence. Among modifiable bleeding risks, PPI therapy has the strongest evidence. A meta-analysis of over 200,000 patients taking DAPT, that is dual antiplatelet therapy, following percutaneous coronary intervention showed pantoprazole substantially reduced gastrointestinal bleeding, and this was significant result. However, the number needed to treat, in the landmark COMPASS trial, pantoprazole 40 mg reduced bleeding from gastroduodenal lesions as well, and that was also statistically significant. However, the number needed to treat was high at 982 patients. A history of upper gastrointestinal lesions remains the single most predictive individual factor. Now, if we look at the recommendations, all patients being prescribed antithrombotic therapy are recommended to have bleeding risk assessment. Modifiable bleeding risks are recommended to be managed. Patient with upper GI tract lesions or high GI bleeding risk should be considered for PPI therapy, and these are all ESVS recommendations. Okay, now let's talk about antithrombotic agents. And we will go through the pharmacology again. I know some of you are tempted to skip this, but don't. The examiner may ask the mechanism of action either in written or your clinical exam. And you all know this is our daily practice bread and butter as a vascular surgeon, so you should know how they really work. Let's start with the antiplatelet agents. COX inhibitors are the aspirin. Aspirin irreversibly inhibits COX-1, which produces thromboxane A2, and this is a potent platelet activator. Because platelets are anucleate, this inhibition lasts for the platelet's entire lifespan, that is 7 to 10 days. So the aspirin inhibits COX-1, and that inhibits production of thromboxane A2, and thromboxane A2 are the potent platelet activator. That means there will be less platelet activation. Low-dose aspirin inhibits only COX-1. At high dose, more than 500 mg, it also inhibits COX-2, inducing prostacyclin production by endothelium, which is why high-dose aspirin is actually prothrombotic in the vessel wall context. This is why low-dose aspirin 75 to 325 mg is used in clinical practice. Okay, so just for you to know, why is low-dose aspirin used rather than high-dose? Low-dose aspirin inhibits only COX-1, that's a platelet thromboxane A2, and high-dose aspirin also inhibits COX-2 in endothelial cells and reducing protective prostacyclin, making it potentially prothrombotic. So low dose gives antiplatelet benefit without this downside. Okay, now ADP receptor inhibitors, or we call it P2Y12 inhibitors. These are the drugs you will prescribe every week of your consultant career. ADP activates platelets via P2Y1 and P2Y12 receptors. P2Y1 is the initiator and P2Y12 is the amplifier. This drug class blocks P2Y12 specifically. So the ADP receptor inhibitors, that is what we use almost always is clopidogrel. They block P2Y12 specifically. So the drugs such as clopidogrel, these are thienopyridine class. So this has also another drug called prasugrel. So both prasugrel and clopidogrel are thienopyridines. And there are other two medication, which is ticagrelor and cangrelor, and these are non-thienopyridines. Now, how this clopidogrel work? These are prodrug and CYP2C9 activation and irreversible P2Y12 block. So the prodrug needs activation and then they irreversibly block the P2Y12. Key point is there are around 30% people who will have genetic poor metabolism, and that's why the drug will not activate in those 30% of patients and remain as prodrug because of CYP2C9 is required for activation and they are genetically deprived of that. PPIs may also reduce the effect. However, no clear cardiovascular outcome data are there for this group of patients, whether this 30% or whether those who are taking PPIs have any adverse cardiovascular outcome. There is no obvious data. Now let's talk about the prasugrel. This is also a prodrug. It's faster and less variable activation, and again it also irreversibly inhibits the P2Y12. This is more potent than clopidogrel but not well studied in PAD. Let's talk about non-thienopyridines, that is ticagrelor. This is not a prodrug and this is reversible P2Y12 inhibition. These are less resistance due to no CYP metabolism and twice daily dosing for ticagrelor. Now the last one is cangrelor. It's a non-thienopyridine. However, this is only IV use and has got very short half-life, and that's why not suitable for cardiovascular prevention. So the key trial that you need to know here is Euclid trial, which compared ticagrelor versus clopidogrel in symptomatic PAD, and the result, there was no difference in major adverse cardiovascular events. And this is why clopidogrel remain the preferred single antiplatelet for lower extremity arterial disease patients, not ticagrelor. Euclid excluded poor clopidogrel metabolizers, and the results may not be generalized to unselected populations. Now the next one will be phosphodiesterase inhibitors, that is cilostazol and dipyridamole. Cilostazol is worth knowing for its claudication benefit. It increases walking distance, but its use is restricted in Europe following a European Medicines Agency review due to concerns about bleeding and cardiac side effects such as tachycardia, palpitation, and headache. No recommendation can be made based on this guideline for cilostazol in lower extremity arterial disease. Dipyridamole alone has little evidence of clinically meaningful antiplatelet effect. It is used in combination with aspirin for secondary stroke prevention. Okay, now that we have discussed about antiplatelet agents, let's talk about anticoagulant agents. These are the unfractionated heparin, low molecular weight heparin, fondaparinux, vitamin K antagonist, that is warfarin, and direct oral anticoagulants, that are DOACs. Okay, let's start with unfractionated heparin. UFH, the unfractionated heparin, enhances antithrombin, which inhibits factor 12A, 11A, 9A, and 10A, and also 2A, which is thrombin. So what are those? 12, 11, 9, 10. These all factors, when they are activated, they are inhibited by the unfractionated heparin via antithrombin 3. After IV bolus, immediate action is achieved by unfractionated heparin. After subcutaneous injection, 60 minutes lag would be there. So IV bolus is needed in an emergency such as acute limb ischemia. Half-life approximately 1 hour and monitored by APTT, and the target APTT ratio is 1.5 to 2.5 times the baseline. For intraoperative use, also use ACT monitoring, activated clotting time, and reversed by protamine. Let's talk about low molecular weight heparin, and these are dalteparin, enoxaparin, tinzaparin, and nedrodaparin. Preferentially inhibit factor 10A over thrombin. And the half-life is 3 to 4 hours, subcutaneous, once or twice daily. No routine monitoring needed except in obesity and renal failure. Monitor via anti-10A level and not reversed completely by protamine, but partial only. Let's talk about fondaparinux. This is a pentasaccharide. Fondaparinux has only anti-10A activity, similar to as low molecular weight heparin. It does not have any anti-2A, that is no antithrombin activity, and half-life is 17 hours, which is much higher than low molecular weight heparin. The low molecular weight heparin had half-life of 3 to 4 hours, but this has half-life of 17 hours. Once daily 2.5 subcutaneous injection. Key use is superficial vein thrombosis, and that was used in Callisto trial in superficial vein thrombosis, and this also requires anti-10A monitoring in CKD patients. Fondaparinux increases bleeding versus low molecular weight heparin in postoperative thromboprophylaxis, an important negative fact. So the low molecular weight heparin has less bleeding risk than fondaparinux in postoperative thromboprophylaxis use. Okay, now vitamin K antagonists, that is warfarin. The VK antagonists inhibit gamma carboxylation of factor 2, 7, 9, and 10. Warfarin half-life is 35 hours, and this takes several days to reach a full effect because factor 2, the prothrombin, has the longest half-life of vitamin K dependent factors. that is 2 to 3 days. This is why early INR changes reflect factor 7 reduction, not full anticoagulation. Critical important point is there is an initial hypercoagulable phase because protein C and S also vitamin K dependent and are depleted first. This is why heparin overlap is mandatory when starting warfarin, except in AF. So why do you need heparin bridging? If you are asked, you say protein C and S, which are natural anticoagulants, are also vitamin K dependent and have shorter half-lives, and that's then the clotting factors, they are depleted first, causing a transient hypercoagulable state, and that's why you need to bridge with heparin. Exception is atrial fibrillation. Okay, now let's compare some of the DOACs, that is direct oral anticoagulants, pharmacology. If you see rivaroxaban, apixaban, and edoxaban, all these three, they target factor 10A. You can see XA1 at the end of their name. That means XA, factor XA, activated factor 10. This is their target. However, dabigatran targets thrombin, that is factor 2A. And you see at the end of dabigatran there is no hexaban. So that's why they don't target, the name did not come from the factor 10A inhibition. Their name is different, and this is dabigatran. And they inhibit thrombin factor 2A. Again, if you want to know the half-life, the edoxaban has amongst the factor 10A inhibitor DOACs, the rivaroxaban had the shortest half-life, that is 5 to 13, and edoxaban had 10 to 14. So rivaroxaban had the shortest half-life. If you see the renal elimination, dabigatran has the highest renal elimination, 80%, and there is some reversal agent which is called endexanet alpha or PCC, and these endexanet alpha and PCC are reversal agent for rivaroxaban and apixaban. However, for edoxaban, only PCC. Importantly, for dabigatran, the reversal agent is idarosuzumab. So this is idarosuzumab. That is the dabigatran's reversal agent. So just to sum up, dabigatran has 80% renal elimination, whereas the rest has around 30% renal elimination. It is DOAC, so it is the DOAC that most affected by renal impairment and accumulates rapidly in CKD. Apixaban has the lowest renal elimination, and that is 30%, and is preferred in CKD. So apixaban you preferred in CKD. And the reversal by idarosuzumab, that is for dabigatran, and endexanet alpha, and that is for rivaroxaban and apixaban, as we mentioned. For PAD, specifically the COMPASS and Voyager trials used rivaroxaban 2.5 mg twice daily. This vascular dose is lower than the AF or VTE doses. It does not require monitoring, and DOACs are generally safer than warfarin for stroke prevention in AF and for VTE treatment. Okay, now we'll go to the disease-specific setting. For carotid disease, antithrombotic management is one of the highest yield areas for the exam. The subtlety is in the detail. Asymptomatic versus symptomatic, pre-carotid endarterectomy versus post-carotid endarterectomy, carotid artery stenting versus carotid endarterectomy, early DAPT versus long-term antithrombotic. So let me go through it. Let's start with asymptomatic atherosclerotic carotid stenosis, more than 50%. So these patients have no stroke or TIA. 2/3 of deaths in patients with asymptomatic carotid stenosis are cardiac. So the antithrombotic goal here is really cardiovascular secondary prevention, not just stroke prevention. And that's why there are two recommendations, 6 and 7, which is specifically focused on asymptomatic more than 50% carotid stenosis. As per the ESVS guideline, aspirin 75 to 325 is recommended for secondary cardiovascular prevention. And aspirin, if it intolerant, then clopidogrel 75 should be considered. And the first one, that is the aspirin, is a class 1 recommendation, and when aspirin intolerant, clopidogrel is a class 2A recommendation. If allergic to both aspirin and clopidogrel, then dipyridamole 200 mg twice daily may be considered. No recommendation for aspirin plus rivaroxaban in asymptomatic carotid disease. Okay, now we move on to symptomatic carotid artery disease, not undergoing intervention. So the pivotal data here come from chance and point trials. DAPT with aspirin plus clopidogrel for 21 days after a minor stroke or high-risk TIA reduces stroke, MI, and cardiovascular death by 30% compared with aspirin alone. This benefit is maximal in the first 21 days, and after 21 days, de-escalate to single antiplatelet, that is clopidogrel, is preferred here, and the long-term DAPT increases bleeding risk without further benefit. So that's the recommendation 8 in symptomatic carotid not undergoing carotid endarterectomy or stenting. DAPT, that is aspirin 75 to 325 mg plus clopidogrel, that is 75 mg for 21 days, then clopidogrel 75 long-term, or aspirin 75 to 100 mg plus dipyridamole 200 mg twice daily. That's also can be another regime for long-term, and this is class 1 recommendation. Thales data, this is another study. It showed if clopidogrel intolerant, then you can go for aspirin plus ticagrelor for 30 days, and that's also a class 2A recommendation. Long-term DAPT, that is aspirin plus clopidogrel, is not recommended, and the evidences that we already says are chance and point trials. Okay, next we talk about antiplatelet therapy before and after carotid endarterectomy. So this time we're talking about the patients who are going for intervention. The ACE trial, that is ACE trial, demonstrated the low-dose aspirin is preferable to high-dose for carotid endarterectomy patients. Combined stroke, MI, or death was lower in the low-dose group at 30 days. that is 5.4 versus 7%, and this was statistically significant. And 3 months was also statistically significant. There is a strong evidence that antiplatelet therapy after carotid endarterectomy improves long-term survival. For patients who are recently symptomatic awaiting carotid endarterectomy, 2 prospective audits show that starting aspirin plus clopidogrel in the TIA clinic reduces recurrent events prior to surgery from 13% to 3% without significantly increasing neck hematomas. So the recommendations for perioperative carotid endarterectomy antithrombotic management. Local protocols for antiplatelet regimes before carotid endarterectomy should be made by local team following major trial regimes. Antiplatelet therapy is recommended before, during, and long-term carotid endarterectomy. Early institution of antiplatelet therapy is recommended in patient awaiting carotid endarterectomy after TIA or minor stroke. DAPT, that is aspirin plus clopidogrel, perioperatively should be considered for recently symptomatic carotid endarterectomy. If monotherapy preferred peri-op, aspirin 300 to 325 mg for 14 days, then 75 to 162 mg that is recommended. Low dose aspirin, that is 75 to 325 mg, is recommended over high dose aspirin. Okay, now antiplatelet therapy before and after carotid artery stenting. Carotid artery stenting has 4 specific thrombotic risks. Number 1, distal embolization from plaque rupture. Number 2, mural thrombus formation from intimal injury. Number 3, stent thrombosis. And number 4, hemodynamic compromise. 2 small RCTs clearly established DAPT superiority over aspirin plus heparin for carotid artery stenting. The CREST trial protocol used aspirin 325 mg daily plus clopidogrel 75 mg daily for more or equals 48 hours before stenting. Then at least 30 days post-procedure aspirin combined with clopidogrel or ticlopidine, followed by single-agent aspirin therapy. So now if we look at the ESVS recommendations for carotid artery stenting antithrombotic management, ESVS guideline recommends DAPT, which is combining aspirin 75 to 325 mg plus clopidogrel 75 mg, is recommended before carotid artery stenting, and clopidogrel should start more or equals to 3 days before or 300 mg loading dose in urgent cases, and that's a class 1 recommendation. DAPT continued for more or equals to 4 weeks post carotid artery stenting, then clopidogrel 75 mg indefinitely, and this is also class 1 recommendation. So after carotid artery stenting, how long should DAPT continue and what single agent used long term? DAPT for at least 4 weeks, that is aspirin plus clopidogrel, then clopidogrel 75 mg indefinitely. This is analogous to coronary stenting but with indefinite clopidogrel rather than aspirin as the long-term agent. Does anticoagulation have a role in atherosclerotic carotid disease? Generally, no. WAVE trial, which is WAVE, WAVE trial, that had a VKA, that is vitamin K antagonist, plus aspirin versus aspirin alone. No major adverse cardiovascular event benefit, but 3-time increased in life-threatening bleeding. If you see the COMPASS carotid subgroup, there was no statistically significant benefit for aspirin plus low-dose rivaroxaban versus aspirin alone, though the subgroup was not powered and many patients were excluded as they need non-aspirin antiplatelet. Okay, now let's talk about atherosclerotic vertebral artery disease. There are no specific trials for antithrombotic therapy in vertebral artery stenosis. Given the identical cardiovascular risk profile, the same recommendations as for carotid disease are adopted. The safety of DAPT has not been specifically assessed in vertebral artery disease. This is recognized knowledge gap in the guidelines. Okay, now we come to the lower extremity arterial disease, LEAD. This is the bread and butter of a vascular surgery antithrombotics, and it's where most exam marks are won or lost. I want you to master the COMPASS and Voyager data, especially these are the two pivotal trials that changed practice. Okay, let's start with the asymptomatic lower extremity arterial disease. The two landmark RCTs, that aspirin for asymptomatic atherosclerotic trial, which has 28,000 patients, had ABI less than 0.95, and the POPAT trial, that is diabetics only who had ABI less or equals 0.99, both showed no benefit for aspirin over placebo in asymptomatic PAD, and the bleeding risk was not substantially lower either. Meta-analysis confirms no meaningful benefit for any antiplatelet combination versus placebo. So, patients with isolated asymptomatic LEAD, that is lower extremity arterial disease, are not recommended to have aspirin for cardiovascular prevention. Asymptomatic PAD or LEAD, whatever you call, no aspirin. Now let's come to chronic symptomatic LEAD, that is lower extremity arterial disease. Once a patient is symptomatic, whether it's claudication, rest pain, or tissue loss, the risk-benefit balance shifts significantly in favor of antithrombotic therapy. There are now two acceptable first-line strategies for secondary cardiovascular prevention in chronic symptomatic LEAD. If we look at the ESVS guideline recommendations for chronic symptomatic lower extremity arterial disease, the medical management recommendation from the ESVS guidelines are as follows. Single antiplatelet therapy is recommended, and that's the strongest evidence, class 1 level A. Clopidogrel 75 mg should be considered as first choice, and this is a class 2A evidence, and that basis is Capri trial. If you remember, clopidogrel versus aspirin, 23.8% relative risk reduction in MACE, that is major adverse cardiovascular events, in the PAD subgroup, and that favored clopidogrel. So remember, clopidogrel is the first choice. Dual antiplatelet therapy is not recommended for secondary cardiovascular prevention, and that is from KARISMA trial. For the PAD subgroup, DAPT showed no significant MACE reduction with increased minor bleeding. So KARISMA said no DAPT. Okay, next, full dose anticoagulation, that is warfarin, is not recommended for secondary prevention in chronic lower extremity arterial disease with no other oral anticoagulation indication as well. So, oral anticoagulation let me tell this again. Full dose anticoagulation, that is VKA, is not recommended for secondary prevention in chronic lower extremity arterial disease with no other oral anticoagulation indication. So if you have no other indication for warfarin, then only for secondary prevention you should not consider an anticoagulation. Okay, next is aspirin 75 to 100 mg plus rivaroxaban 2.5 mg twice daily should be considered in patients not at high bleeding risk, especially those at higher ischemic risk. So this is a class 2A recommendation in ESVS guideline. So potentially, if the patient has higher ischemic risk, you can consider this regime. Now let's do a deep dive in COMPASS trial, and this is the pivotal evidence for aspirin and rivaroxaban. If you see, almost 27,000 patients were enrolled, and these patients were atherosclerotic vascular disease, and they were stable atherosclerotic vascular disease. The lower extremity arterial disease had a subgroup of around 4,000 patients. Intervention was rivaroxaban 2.5 mg BD plus 100 mg aspirin OD versus aspirin 100 mg OD alone. Cardiovascular death plus MI plus a stroke, that was composite MACE, that is major adverse cardiovascular event. This was the primary outcome. Overall result, if you see, the hazard ratio was 0.76, favoring combination therapy, as MACE was reduced but major bleeding increased with a hazard ratio of 1.7. LEAD subgroup, that is the lower extremity arterial disease subgroup, had a net benefit, 22% net clinical benefit, when MACE plus MALE, that is major adverse cardiovascular event plus major adverse limb events, including major amputation, balanced against fatal critical organ bleeding. That means 22% net benefit. COMPASS exclusion criteria was high risk of bleeding. In clinical fields, high bleeding risk, stroke within 1 month, hemorrhagic or lacunar stroke history, hepatic coagulopathy, these were the exclusion criteria. Now, very important point to remember, there is no head-to-head RCT comparing clopidogrel alone versus aspirin plus rivaroxaban for chronic symptomatic PAD or LEAD. A network meta-analysis shows similar efficacy for both over aspirin alone. Therefore, both clopidogrel 75 mg and aspirin plus rivaroxaban low dose BD are acceptable choices. So this is evident by a network meta-analysis which showed the similar efficacy between the clopidogrel and this combination therapy. Now you may be asked to justify either. you know both, then you can give the evidence. A real-world study showed only 30% of PAD patients are actually eligible for COMPASS criteria. High bleeding risk is common in this population. So, in summary, it looks like that the clopidogrel alone should be the better choice, unless there is severe ischemia risk or higher ischemia risk that we just mentioned earlier. Okay, now we are moving to high ischemic risk in LAD when to escalate to antithrombotics. This is important again for you to remember. Risk stratification for male or MACE is fundamental to the exam. The following clinical risk factors confer significantly higher rates of amputation and death. The presence of any one of the following factors classifies a patient as a high risk and is used to prioritize the aspirin plus rivaroxaban combination. So this is important for you to remember the following category. So high ischemic risk factors, any one of the followings, which are symptomatic arterial disease in more than one territory, that is polyvascular disease, chronic kidney disease including dialysis-dependent renal failure, diabetes mellitus, heart failure, chronic limb-threatening ischemia, that is CLTI itself should warrant this combination therapy, acute presentation of chronic LAD, previous lower limb amputation, previous lower limb revascularization. So this is really important to know which patients you favor because of high ischemia risk, this combination therapy of aspirin and rivaroxaban. So these patients are as follows. I repeat again: symptomatic arterial disease in more than one territory, chronic kidney disease including end-stage renal disease, diabetes mellitus, heart failure, CLTI patients, acute presentation of chronic lower extremity disease, previous lower limb amputation, previous lower limb revascularization. Now, there is one thing to remember: COMPASS and Voyager pad both excluded if the patient had a low eGFR of less than 15 ml per minute per 1.73 square meter. And the absolute benefit of aspirin and rivaroxaban was uncertain in this group. So remember to check the eGFR before deciding the regime. Now we move on to acute presentation of chronic LAD or acute limb ischemia on a background of chronic disease. Patients with established lower extremity arterial disease who develop ALI, that is the acute lower limb ischemia, are at particular elevated MACE and male risk. In Voyager, ALI was the most commonly reported endpoint over 28 months. Euclid trial showed that patients who developed ALI had hazard ratio of 1.4 for MACE and hazard ratio of 3.3 for all-cause death and hazard ratio of 14.2 for a major amputation. These numbers illustrate the catastrophic prognosis of ALI on a background of LAD. Let's look at the recommendation from the ESVS guideline for acute limb ischemia on a background of chronic disease. Patients with ALI are recommended to have immediate IV unfractionated heparin or low molecular weight heparin to prevent thrombus propagation. Patients with ALI planned for expedited revascularization are recommended to have immediate IV unfractionated heparin. About the dosing, unfractionated heparin bolus 5000 international unit, then 1000 to 2000 international unit per hour, or weight adjusted low molecular weight heparin, that is enoxaparin, 1 mg per kilogram BD or 1.5 mg per kilogram OD. Okay, now we move on to intraprocedural anticoagulation. We compare what to do in endovascular and open. So heparin is standard practice for both endovascular and open arterial surgery for all our daily practice. The evidence is interesting. In 1990, RCT showed perioperative MI rate was 1.4% with unfractionated heparin versus 5.7% without it when doing open AAA repair, and this was a compelling argument for its use. A subsequent RCT comparing unfractionated heparin with 60 units per kilogram versus low molecular weight heparin, that is enoxaparin 0.5 mg per kilogram during lower extremity arterial disease revascularization intervention. Enoxaparin was safer, but bleeding composite versus enoxaparin was safer, bleeding composite 2.4% versus 10.5%. Bivalirudin also has evidence in peripheral endovascular procedures, lower mortality, MACE, and bleeding versus unfractionated heparin in meta-analysis, though most studies were retrospective. So if we look at the recommendation from as per the ESVS guideline, during endovascular intervention, IV or intraarterial unfractionated heparin 50 to 100 units per kilogram or low molecular weight heparin 0.5 mg per kilogram is recommended as class 1 evidence. Open arterial surgery, bolus unfractionated heparin, that is 50 to 100 units per kilogram, should be considered. Intraoperative APTT or APTT ratio or ACT monitoring may be considered for further unfractionated heparin dosing or reversal, and that's a class 2B recommendation, so it's not a strong recommendation. Bivalirudin 0.75 mg per kilogram may be considered as alternative to heparin in endovascular procedures, and this is also a class 2B recommendation. Now, what about post-endovascular intervention? That comes the Voyager evidence. The Voyager trial is the definitive modern trial for post-revascularization antithrombotics. It enrolled 6,500 patients with chronic lower limb atherosclerotic disease undergoing revascularization. 66% underwent endovascular and 34% surgical. Primary efficacy outcomes was a composite of ALI, major amputation, MI, ischemic stroke, or cardiovascular death. So if we look at the treatment arm, this was aspirin 100 mg OD plus rivaroxaban 2.5 mg BD versus aspirin 100 mg OD plus placebo. Primary efficacy was hazard ratio 0.85, that is significant reduction with aspirin and rivaroxaban. major bleeding, no significant increase. ISTH major bleeding, significant increase. Key driver of benefit was reduction in ALI, and that was the main outcome driving significance, which had a hazard ratio of 0.67. So surgical versus endovascular, if you see the surgical subgroup had a hazard ratio of 0.79, that was significant. And in endovascular group, the hazard ratio was 0.90, and that was not significant. However, there was no significant interaction between subgroups. Concomitant clopidogrel, around 51% received clopidogrel non-randomly. Adding clopidogrel for more than 30 days increased ISTH major bleeding without improving primary endpoint. So now let's see what the ESVS guideline recommends for post-endovascular LEAD. DAPT, that is aspirin 75 mg plus clopidogrel 75 mg, may be considered for 1 to 6 month post-endovascular intervention if they don't have high bleeding risk. And aspirin 75 to 100 mg plus rivaroxaban 2.5 mg BD should be considered post-endovascular procedure if there is no higher bleeding risk. Adding clopidogrel to aspirin plus rivaroxaban is not recommended beyond 30 days. Bleeding risk outweigh the benefit. Okay, now what about the open bypass surgery? Here comes the Dutch BOA trial and the Voyager surgical subgroup. The Dutch BOA, that is the bypass oral anticoagulants or aspirin, that is BOA, trial is the landmark study here, which included around 2,600 patients, and they underwent infrainguinal bypass and were randomized to warfarin, that is the VKA, with the INR target of 3 to 4.5 versus aspirin 80 mg, and overall no difference in graft occlusion. However, there was a striking graft type interaction. Dutch BOA trial, the key interaction by graft type was vein graft. The warfarin, that is the VKA, was better with a hazard ratio of 0.69 for graft occlusion, and the prosthetic graft aspirin was better. Major bleeding, the warfarin, that is the VKA group, had twice the rate versus aspirin. The INR target was high 3 to 4.5, and patients were in range only in 50% of the time. So the guideline consensus, if VKA is used for vein bypass, target INR should be 2 to 3 with aim of 2.5, and that's a class 2A recommendation, not the 3 to 4.5 used in Dutch BOA trial. Okay, now the recommendation for the post-bypass antithrombotic therapy. So aspirin 75 to 100 mg plus rivaroxaban 2.5 mg BD should be considered after infrainguinal bypass, that is endarterectomy, autologous vein or prosthetic conduit, if they don't have any high bleeding risk. Adding clopidogrel to aspirin plus rivaroxaban is not recommended beyond 30 days. VKA, that is warfarin, may be considered to improve patency of autologous vein infrainguinal bypass. If VKA used for vein bypass, target INR should be 2 to 3 with aim of 2.5. Single antiplatelet may be considered for prosthetic conduit infrainguinal bypass. High bleeding risk patients may be considered for single antiplatelet. These are the ESVS recommendation. Now, very important to remember, if you have a patient who has just had a below-knee vein bypass for CLTI, they are not at high bleeding risk. What is the first line postoperative antithrombotic? You say aspirin 75 to 100 mg OD plus rivaroxaban 2.5 mg BD as per the Voyager PAT trial, as the Voyager subgroup had this, and this is a ESVS recommendation class 2A evidence. Warfarin is also an option for vein bypass. This is a class 2B evidence in the ESVS guideline, and if used, target INR should be 2 to 3. Single antiplatelet is the fallback for high bleeding risk patient. So that's your algorithm. The preference would be the Voyager regime. For the vein bypass, of course. A patient with prosthetic FEMPOP bypass, what would be the regime? First choice would be again aspirin 75 to 100 mg plus rivaroxaban 2.5 mg BD. If high bleeding risk, single antiplatelet is preferred over warfarin for prosthetic conduit. DAPT is not the default. And in Dutch BOA trial showed aspirin better than warfarin for prosthetic patency. Okay, now we move on to the patients with pre-existing indication for full dose anticoagulation, such as atrial fibrillation. This is a genuinely difficult clinical and exam scenario. A patient with atrial fibrillation on warfarin undergoes a femoral angioplasty. Do you add aspirin or clopidogrel? The answer from the guideline is clear and somewhat continuity to those trained purely in cardiology. Patients with PAD plus pre-existing oral anticoagulation indication, or that is such as AF, do not routinely add antiplatelet therapy to full dose anticoagulation. Stop the antiplatelet if full dose DOAC starts. In exceptional post-endovascular circumstances, single antiplatelet for maximum 3 months may be considered. This is different from cardiology practice, where triple therapy is sometimes used after coronary stenting. In PAD, there is no RCT evidence for benefit and clear evidence of harm is there. These recommendations do not apply to the aspirin plus rivaroxaban combination. Now we will move on to aneurysm dissection, non-atheromatous PAD, and dialysis access. Let's start with abdominal aortic aneurysm. Patients with small AAA carry 3% per annum cardiovascular mortality, primarily cardiac. There are no specific RCTs of antiplatelet therapy for AAA alone. Meta-analysis shows no reduction in all-cause mortality for antiplatelet versus placebo in small AAA. Though a large prospective cohort, that is 12,400 patients, showed improved 5-year survival on antiplatelets, there is no convincing evidence for aspirin reducing aneurysm growth. A 12-month RCT comparing ticagrelor versus aspirin for AAA growth found no difference in sac expansion. So if you look at the ESVS recommendation, small AAA aspirin 75 to 100 mg may be considered for cardiovascular event reduction. And this is a class 2B recommendation. Post-open or EVA repair, aspirin 75 to 100 mg should be considered for secondary cardiovascular prevention. This is a class 2A recommendation. No recommendation for DAPT or aspirin plus rivaroxaban in AAA specifically. If you see the POISE-2 signal in the vascular surgery subgroup, including 265 AAA patients, perioperative aspirin showed a trend toward more death and MI in AAA patients with a hazard ratio of 1.48, and major bleeding was not increased. This signal means no firm recommendation can be made for or against continuing aspirin perioperatively for AAA repair. This is something to take on. Now, if we talk about the popliteal artery aneurysm, evidence is based on 5 observational studies, no RCTs. Single antiplatelet is recommended for both surveillance and post-repair management. There is no evidence supporting more aggressive regime. Post-operative aspirin and rivaroxaban are not specifically recommended for popliteal aneurysm repair, though are not contraindicated either. So if we look at the ESVS recommendation, single antiplatelet should be considered for popliteal aneurysm under surveillance. Single antiplatelet post-open popliteal repair may be considered. Okay, now what about arterial dissection? If we talk about extracranial, carotid and vertebral artery dissection, this is a topic that appears in both the neurology and vascular surgery exam. The CADIS trial, which we already said before, is a randomized trial who randomized 250 patients, 118 carotid and 132 vertebral, to antiplatelets versus anticoagulation. TREAT-CAD trial that randomizes 194 patients to aspirin versus warfarin, that is VKA. Neither showed any difference in outcome. The guidelines therefore recommend antiplatelet as the default because anticoagulation is no better but is risk of bleeding. So extracranial, carotid or vertebral artery dissection, single antiplatelet at least 3 months is recommended as per the ESVS guideline, and this is a class 1 recommendation. Anticoagulation is no better than antiplatelet, that has been proved by CADIS and TREAT-CAD trials, and carries higher bleeding risk, therefore not recommended as default. Now what about the superior mesenteric artery dissection? Meta-analysis of 35 studies, including 725 patients, showed no benefit for antithrombotic therapy over no treatment in terms of dissection, resolution or progression. However, given the risk of ischemic bowel events, the consensus is single antiplatelet. Single antiplatelet should be considered for isolated superior mesenteric artery dissection as a class 2A recommendation in ESVS guideline. What about the renal and mesenteric atherosclerotic disease? There are no RCTs in this space. Recommendation extrapolated from general PAD evidence and lower quality retrospective cohort study. As per the ESVS guideline, single antiplatelet should be considered for secondary cardiovascular prevention in more than 50%, or mesenteric artery stenosis class 2A level C. Another recommendation, the post-revascularization short course DAPT aspirin plus clopidogrel for 1 to 6 months be considered for stent thrombosis prevention. So just to recap, for more than 50% stenosis for renal and SMA, you consider single antiplatelet, or even if it is asymptomatic, you still consider single antiplatelet for secondary prevention. However, that you should be considering DAPT for 1 to 6 months after post-revascularization to prevent stent thrombosis. Okay, now what about the vascular access for hemodialysis? This is an underappreciated area for the exam. 3 key decision points: intraoperative heparin, short-term antiplatelet for fistula maturation, and long-term antiplatelet for graft patency. If we look at the ESVS recommendation for dialysis access antithrombotics, systemic unfractionated heparin is not recommended during AV fistula or AV graft formation, and because this increases bleeding without late patency benefit. Now, AV fistula formation, clopidogrel 75 mg for up to 6 months should be considered as first line to improve patency, and this is a class 2A recommendation. And this evidence is based on a large RCT of 877 patients with clopidogrel reduced early thrombosis with a relative risk of 0.63. And again, for AV fistula, aspirin 75 to 100 mg for up to 6 months may be considered if clopidogrel is contraindicated, and that's a class 2B recommendation. Now, AV graft formation, single antiplatelet for up to 6 months may be considered, that's a class 2B recommendation. So you can see that single antiplatelet is recommended for 6 months for either you do AV fistula or graft, and the first preference is clopidogrel. No recommendation for long-term antiplatelet beyond 6 months. This is important to remember as well. So, you form an AVF under local anesthetics. The patient asks if they need any medication. What would you recommend? Do not give systemic heparin and start clopidogrel 75 mg for up to 6 months post-formation. If clopidogrel contraindicated, then aspirin instead, and that should be 75 to 100 mg. And this is evidence-based from the trial that was published in December 2008 and included 877 patients. Now we will talk about some special populations, that is, patient with chronic kidney disease, cancer, or thrombophilias. Let's start with chronic kidney disease, CKD. CKD is one of the most common comorbidities in our vascular surgery patients. It independently increases both thrombotic risk, that is ischemic events, and bleeding risk due to platelet dysfunction, coagulation abnormalities, and so on. The key exam scenario is choosing the right anticoagulant for a PAD patient with CKD. Now, what are the antithrombotic choices in CKD patient? If you have a CKD stage 3 to 4, that is eGFR between 15 and 59 or around 660, so 15 and 59, the anticoagulation for PAD should be DOACs, may be considered, that's a class 2B recommendation. Anticoagulation for VTE prevention is DOACs, should be considered. Low molecular weight heparin in stage 3 to 4 should be monitored with dose adjustment, and CKD stage 5, that is EGFR less than 15, the VKA warfarin may be considered as an alternative to DOAC in severe end-stage CKD. As you also remember that the Voyager, PED and COMPASS, they excluded this group of patients because of the DOAC would not be appropriate for this low EGFR. And apixaban has lowest renal elimination, if you remember, 30%, and is preferred DOAC in CKD, so that the renal elimination is less, and that's why apixaban is the preferred DOAC in CKD. Dabigatran has 80% renal clearance, that's why avoid insignificant renal impairment. CKD increases ischemic risk, and that qualifies as high ischemic risk factor, as we discussed before, if you remember. COMPASS included patients with EGFR 15 to 30, that is stage 4 to 5, and the aspirin plus rivaroxaban appeared effective across all CKD stages included in this trial, but uncertain in dialysis patients who had lower EGFR. So if we want to say anticoagulation will depend on if you are treating as PAD, then you can consider DOAC. If you are treating a VTE prevention, and DOAC should be considered, and low molecular weight heparin in stage 3 and 4 needs dose adjustment. And of course, you have already known that EGFR less than 15, this is a stage 5, you then consider warfarin. Okay, now we talk about the patients with thrombophilias. Now, thrombophilia is a rare cause of arterial thromboembolic events. Overall, the most clinical relevant for arterial event is antiphospholipid syndrome, that is APS. Factor V laden and prothrombin G2021-0A are predominantly venous thrombophilias, but carry slightly elevated arterial risk as well, particularly in those under 55 years old. So factor V laden and prothrombin G2021-0A, these are mostly venous thrombophilias, and APS, that is antiphospholipid syndrome, is mostly arterial events. So the recommendation says antiphospholipid syndrome presenting with arterial embolism, VKA with target INR between 2 to 3 is recommended, and that's a class 1 recommendation. DOACs may increase stroke risk over VKA in APS, and that was found in a Cochrane review of 8 studies. For APS, VKA is preferred, not DOAC. So when to test for thrombophilia? Testing should be highly selective if investigating after an unprovoked arterial embolus. Wait at least 3 months of anticoagulation before testing. Always involve a hematologist, and there is no consensus on testing versus not testing, conflicting guidance from major bodies. Finally, the cancer-associated arterial thromboembolic events. Arterial thromboembolic risk is higher from 5 months before cancer diagnosis and peaks 30 days before diagnosis. Cumulative incidence is 0.62% versus 0.11% in control, and this was statistically significant. MI and ischemic stroke risk is more than 2 times higher within 6 months of cancer diagnosis. There are insufficient RCT data for arterial events in cancer. Extrapolation from cancer-associated VTE data is used in practice. Okay, now the important part is the venous disease, DVT, SVT, cancer, VTE, venous intervention. Now, venous antithrombotic therapy is equally examined, especially in European board exam as well as FRCS exam. The key themes here are DOACs versus VKA for DVT treatment, fondaparinux for SBT, extended anticoagulation decisions, and cancer-associated VTE. So we will start with deep venous thrombosis. The principal treatment phase is the first 3 months. The meta-analysis of phase 3 trials comparing DOACs versus VKA, that is warfarin, for VTE treatment is definitive. DOACs are equivalent in efficacy with a relative risk of 0.89, with less bleeding, that is major bleeding, relative risk is 0.63. Net clinical benefit favors DOACs. If we look at the apixaban, that has the less bleeding with a relative risk of 0.44. And if we look at the recommendation from ESVS guideline, proximal DVT, 3-month course of full dose DOAC over VKA is recommended, and this is the strongest evidence, class 1 level A. So 3-month DOAC is recommended over VKA for proximal DVT, and that should be treatment dose. Extended anticoagulation after 3 months, full dose DOAC over VKA should be considered. Again, this is class 2A recommendation. If you find an unprovoked DVT, aspirin for extended phase is not recommended when eligible for anticoagulants. If we see another recommendation for unprovoked proximal DVT, not at high recurrent risk, the reduced dose apixaban 2.5 mg BD or rivaroxaban 10 mg OD after 3-month principal phase should be considered. Just for you to remember here that the dosing for extensive course is apixaban 2.5 BD, not rivaroxaban, because the Compass and Vajrapad had rivaroxaban 2.5 BD. This is apixaban 2.5 BD, and here the rivaroxaban is 10 mg OD after 3 months. So just remember, don't mix it up with that. Okay, so just again, reduced dose DOACs apixaban 2.5 mg BD or rivaroxaban 10 mg OD are as effective as full dose for extended phase in unprovoked DVT, not at high recurrence risk. They are more effective than aspirin or placebo. This distinction, principal versus extended phase dosing, is very important to remember. DVT in antiphospholipid syndrome, that is triple positive APS or APS with history of arterial or small vessel thrombosis, do not use DOAC. Use VKA, that is warfarin. Any antiphospholipid syndrome, remember VKA, that is the treatment. For low risk APS, that is single or double antibody positive, you can use DOACs, especially apixaban or dabigatran, may be appropriate pending further evidence. However, antiphospholipid syndrome, remember warfarin. Okay, now we move on to superficial vein thrombosis, that is SVT, and this is commonly misdiagnosed as cellulitis. In a large prospective study, thromboembolic complications, that is DVT, PE progression, or even recurrence, occurred in 10.2% within 3 months. The Callisto RCT that had 3,000 patients established fondaparinux as the gold standard, 85% reduction in primary efficacy outcome versus placebo, that is 0.9% versus 5.9%. The Surprise trial showed rivaroxaban 10 mg was non-inferior to fondaparinux for 45 days. Now let's look at the ESVS guideline for superficial vein thrombosis. If the SVT is more or equals 3 cm from deep vein junction and 5 or more centimeter in length, then fondaparinux 2.5 mg once daily for 45 days is recommended as class 1 evidence. So remember, SVT, if it is more or equals 3 cm from deep vein junction and more or equals 5 cm in length, fondaparinux 2.5 mg OD for 45 days, and this is class 1 recommendation. Rivaroxaban 10 mg OD or intermediate dose low molecular weight heparin OD should be considered as an alternative to fondaparinux, and that's a class 2A recommendation. However, if the SVT is less than 3 cm from deep vein junction, then you treat this as a DVT and you do full dose anticoagulation for 3 months, and that is recommended. So remember this cutoff of 3 cm. If it is 3 cm or more away from the deep vein junction, then you do the fondaparinux 2.5 mg for 45 days. And if it is, of course, if it is more than 5 cm length, more or equals 5 cm length. However, if it is less than 3 cm from the deep vein, then you do as a full dose of anticoagulation, and that is for 3 months. This is very important for the exam to remember. Now, the SVT with high risk features, then the 3-month rather than 45 days intermediate dose anticoagulation may be considered. The high-risk SVT features are extensive calf plus thigh SVT, recurrent SVTs, thigh-level SVTs, great or short saphenous near junction, cancer-related, or thrombophilia-related. In these high-risk categories, you can consider, instead of 45-day, doubling the duration to 3 months. Okay, now let's move on to the cancer-associated VTE. Cancer is associated with 17 to 29% of all VTE cases. VTE risk is 7-fold higher in cancer versus non-cancer patients. Hematological malignancies carry the highest risk, followed by lung and GI cancers. Mortality is 3-fold higher after VTE in cancer patients. Okay, if we look at the ESVS recommendation now, the cancer-associated VTE anticoagulation with low molecular weight heparin is recommended. And that's the strongest recommendation, class 1, level A. and low molecular weight heparin is superior to VKA, that is warfarin, for preventing recurrent VTE. Cancer-associated VTE with low risk of GI or GU bleeding, consider DOAC, preferably apixaban, or alternative rivaroxaban or edoxaban, as an alternative to low molecular weight heparin, and that's also a class 1 evidence. However, remember, DOACs associated with increased clinically relevant non-major bleeding versus low molecular weight heparin, and predominantly in GI luminal malignancies. In GI or GU cancer, use low molecular weight heparin first. Okay, now we move on to post-venous intervention, that is for DVT, thrombolysis, thrombectomy, or venous stenting. This is an area of genuinely low evidence, a major research gap identified explicitly in the guidelines. A consensus statement recommends warfarin after acute DVT intervention, but DOACs are now widely used given their class benefit over warfarin for DVT. So the ESVS recommends iliofemoral venous stenting. Individualized antithrombotic regime should be considered, taking consideration the bleeding risk. Post-DVT intervention, anticoagulation at least as long as a standard DVT treatment, and that is the recommendation as class 1. Okay, now we talk about the VTE prophylaxis in vascular surgery. All vascular surgery patients need a personalized VTE risk assessment. A meta-analysis of 42 publications that included 20,000 patients showed that VTE rates were similar between patients receiving or not receiving prophylaxis, and that was 1.5% versus 0.96%. There is no validated VTE risk scoring system specifically for vascular surgery patients. The ESVS guideline recommendations are as follows. All vascular surgery patients are recommended to have an individualized, personalized VTE risk assessment, and that's a class 1 recommendation. High ligation and stripping of GSB patient at higher DVT risk and should be considered for low molecular weight heparin thromboprophylaxis. Endovenous ablation of GSB patients at higher DVT risk also should be considered for low molecular weight thromboprophylaxis. If patient already an aggressive antithrombotic therapy such as aspirin and rivaroxaban or DAPT, then reduced the need of prophylactic low molecular weight heparin, and this reflect in risk assessment. Now, as we just said, the previous 2 recommendations that very high VT risk patients who are going for open surgery or endovenous ablation consider low molecular weight heparin, that should be continued for up to 6 weeks post-operatively. Okay, now before finishing, let's do a take-home summary of this episode. Everything that we are going to summarize now are really exam relevant. If you know all of these, this will be very helpful for the exam. Okay, let's start with summarizing the pharmacology. Aspirin, irreversible COX-1 inhibitor, low dose, antiplatelet only, high dose also inhibits endothelial prostacyclin. Clopidogrel prodrug, that is CYP2C9, and this inhibits irreversibly P2Y12. However, 30% are poor metabolizers, and PPIs may also reduce the activity of this prodrug. Ticagrelor, not a prodrug, and this is reversible, and this reversibly block P2Y12, and Euclid study showed it is not superior to clopidogrel. Warfarin, initial hypercoagulable phase, that is protein C and S also depleted in the first few days. So heparin overlap mandatory except in AF, and half-life is 35 hours for warfarin. Dabigatran had 80% renal clearance, so avoid insignificant CKD, and this is reversed by idarucizumab. Apixaban has lowest renal elimination, that is 30%, and that's why preferred DOAC in CKD, and the reversal is andexanet alpha or PCC. Vascular dose for rivaroxaban is 2.5 mg twice daily, not a 10 mg or 20 mg dose. Vascular dose for LEAD, that is lower extremity arterial disease, of rivaroxaban is 2.5 mg twice daily, not the 10 mg or 20 mg dose which is used in VTE or AF. Unfractionated heparin reversed by protamine, low molecular weight, only partially reversed by protamine. Now let's summarize the bleeding risk. PAD score developed from 81,000 German PAD patients, and this predicts major bleeding at 1 year, and highest score is anemia patient, and that is giving you 8 points, and next walk, pre-admission and prior bleeding gives you 5 points. Risk groups: low is 0, low to moderate 1 to 4, moderate to high 5 to 9, and high is more or equals to 10 points. Not yet externally validated and used as one tool in clinical decision making. PPI reduces GI bleeding on depth and with a relative risk of 0.32, and the pantoprazole 40 mg in COMPASS had a hazard ratio of 0.52. For carotid disease, asymptomatic more than 75% stenosis, aspirin 75 to 325. Symptomatic, not undergoing intervention, DAPT for 21 days, then single antiplatelet. No long-term DAPT in carotid disease. CEA, low-dose aspirin preferred over high-dose. Lifelong antiplatelet after CEA. CAS, DAPT from more or equals to 3 days pre-procedure or 300 mg clopidogrel loading dose, and continue more or equals 4 weeks post CAS, then clopidogrel indefinitely. Cervical dissection, antiplatelet for more or equals to 3 months, not anticoagulants as default, and this is class 1 recommendation. Now let's summarize the lower limb PAD. Asymptomatic LEAD or PAD, no aspirin. Chronic symptomatic LEAD, single antiplatelet is recommended, and that's clopidogrel preferred over aspirin. Dual antiplatelet for chronic LEAD not recommended. Aspirin plus rivaroxaban 2.5 BD should be considered if no high-risk bleeding is present, especially with high ischemic risk. COMPASS LEAD net benefit hazard ratio of 0.78. Voyager aspirin plus rivaroxaban reduces primary composite post revascularization, and main driver as reduced ALI. Voyager adding clopidogrel more than 30 days to aspirin plus rivaroxaban is not recommended. Intraprocedural heparin, we said 50 to 100 unit per kilogram, and enoxaparin 0.5 milligram per kilogram, and both are safer. Bypass with vein, you choose VKA, that is warfarin, or aspirin plus rivaroxaban. If VKA, then the target INR is 223. Bypass with prosthetic, single antiplatelet, or aspirin plus rivaroxaban. That means prosthetic, you need antiplatelet there. Dutch BOA, VKA, that is the warfarin, INR target they used were 3 to 4.5. Better vein bypass, however aspirin better for prosthetic bypass. This was the finding of Dutch BOA trial. Plus pre-existing WOC or DOAC, do not add antiplatelet, stop antiplatelet when WOC starts. High ischemic risk factors, polyvascular disease such as CKD, diabetes, heart failure, CLTI, ALI, prior amputation, prior revascularization. In this case, consider the Voyager PAD regime, which is low-dose aspirin plus low-dose rivaroxaban. Now, let's summarize the aneurysm and special topics. The small AAA aspirin may be considered for cardiovascular prevention only. Post-AAA repair aspirin should be considered. POES2 signal trend towards increased death or MI with perioperative aspirin in AAA subgroup. No firm recommendation is there about it. For AVF, that is arteriovenous fistula, no systematic heparin intraoperatively. However, clopidogrel 75 mg for up to 6 months of the fistula formation is recommended as class 2A recommendation. Antiphospholipid syndrome plus arterial event, VKA, is recommended with a target INR of 2 to 3, not the DOAC, as the DOAC has an increased risk of stroke. Now, let's summarize the venous disease. Proximal DVT, you do 3-month full DOAC over VKA is recommended, and that's a class 1 and level A evidence. Extended phase DVT, that is low recurrence risk. Reduced dose apixaban 2.5 mg BD or rivaroxaban 10 mg OD is recommended. Unprovoked DVT, aspirin for extended phase is not recommended when WOC is an option. SVT, Mororicus 5 cm in length and Mororicus to 3 cm from the junction, you consider fondaparinux 2.5 mg OD for 45 days. SVT less than 3 cm from the junction, you do full anticoagulation, and that's for 3 months. Cancer VTE, low molecular weight heparin is recommended as a class 1 level A. If low GI or GU bleeding risk, DOAC, that is apixaban, is preferred, and that is recommended as alternative. Antiphospholipid syndrome plus DVT, and that is in triple positive or arterial thrombosis history, you consider VKA, not DOAC. For APS, generally remember VKA or warfarin is the recommendation. Now, some important points. Euclid excluded poor clopidogrel metabolizers, so results may not generalize fully. Compass excluded patient on non-aspirin antiplatelets, so excludes most asymptomatic carotid patients. Rivaroxaban vascular dose is 2.5 mg BD, not 10 mg or 20 mg, and this is for PAD or lower extremity arterial disease. Aspirin plus rivaroxaban is not the same as DOAC monotherapy. It is dual pathway inhibition strategy. Cilostazol is not recommended for a post-endovascular intervention in the guideline. Fondaparinux increased bleeding versus low molecular weight heparin in postoperative prophylaxis. In CKD, DOAC preferred over VKA for VTE, but VK preferred over DOAC in APS. Dutch BOA used INR target of 3 to 4 and is too high, and the guideline recommend INR target 2 to 3. Long-term DAPT after carotid intervention is not recommended, and intraoperative unfractionated heparin for AV fistula not recommended. Thank you very much. We are at the end of this episode. Thanks for listening to Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned because in the next episode we will discuss radiation safety in vascular surgery. We will talk about units and dosimetric parameters, biological effects, radiation reduction techniques, and personal protective equipment, all based on ESVS guideline. Very important topic for written exams. As always, with your support, we will grow together. Keep listening to Proximal Control because in vascular surgery, control is everything.